Welcome everyone to this webinar for the AASNS, which is focusing on cervical spine surgery, particularly in the subaxial cervical spine, which is from C3 to C7. And we're going to have a look at the essentials of surgery and some tips and tricks along the way from our expert speakers. My name's Dr. Tanya Yuen, and I'm a neurosurgeon at the Royal Melbourne Hospital. I've got an interest in complex spine and neuro-oncology. I'd like to thank Dr. Kate Drummond, Professor Kate Drummond, who is president of the AASNS, Dr. Sinha, who's the secretary, Dr. Vincent, who's the assistant secretary, Professor Yigal Shashan, who is the chair of the education committee, and also my co-conveners of the webinar series, Dr. Rachel Grossman and Manjul Tripathi. So I'll just share my screen. By way of introduction to these topics, I'm first going to give you some perspectives on the concepts of alignment of the cervical spine. So, good alignment of the cervical spine more often than not means good sagittal balance. And sagittal balance, or this cone of economy concept, is a biomechanical concept that there is a range of positions of the person in an upright posture that is easily and comfortably maintained by minimal muscle effort with predominant loading on the posterior columns. Now, if the body falls outside this cone, significantly more muscle activity is required to stay upright, with excess loading on the anterior column, potentially leading to pain and disability. Now, the sagittal balance concepts are mainly used initially by the deformity spine surgeons who do the long span thoracolumbar fusions. But in the last decade or so, we've come to realize that sagittal alignment of the cervical spine has an impact on clinical outcomes, not necessarily in isolation, but in a global cranial and spinal sense. The alignment of the spine stems from the evolution of us as humans who have become bipedal in walking upright, and we require flexibility and strength to do this. The lumbar spine should be lordotic and the sacrum kyphotic, with the pelvis tilted down to enable bipedal standing and walking. The thoracic spine should be kyphotic to counterbalance the rib cage over the lumbar spine below. And the cervical spine, which is the most flexible, and needs to balance the heavy head over the rest of the spine and the pelvis in order to maintain a horizontal gaze in order for us to be able to walk. As the spine degenerates, it kyphoses, and as the heavy head falls forward, the need for horizontal gaze triggers compensatory mechanisms in the spine and the pelvis and the legs. You can see here the pelvis is, in order to compensate for that, the pelvis is retroverted, the knees are bent, and the head is cantilevered back in order to be able to be upright, in order to be able to see when they walk. So this evaluation of the whole spine allows us to determine the extent of correction for that particular part of the spine, but also to favour a more balanced outcome for the whole spine and the head complex. So taking these different spinal parameters into account also enables us to understand complications that can involve the type of long span surgery, such as proximal junctional kyphosis that leads to pain and reduced function and may require further surgery in the future. So how is sagittal balance measured? In the old days, 36-inch films were used, and the early spinal surgeons used to do the measurements manually. But these days there are EOS scans, which stands for Extreme Orthopedic Imaging Systems. And these are low-dose X-ray imaging systems that produce 3D images of the body whilst the patient stands or weight bears. All of our MRIs and CT scans are performed in the lying position. So having these scans in a weight-bearing position gives us more of an indication of the deformity that could be occurring whilst we stand and walk. Actually, I'll just go back. So here you can see an example. There's one parameter called an SVA, which basically implies that the head is well forward of the rest of the body. And as you can see here, there's requiring a lot of strain on the back in order to stand upright. And after the appropriate surgery, where there's recreation of the lordosis, you can see that the head is cantilevered back over the rest of the spine, and that's a more relaxed position. So that's where these parameters can help objectively help us to reach more of a sagittal balance profile. So what is normal alignment? There are 5 distinct profiles of the cervical spine, mainly because it's so flexible, most of which are lordosis and the neutral position, but there's also kyphosis, S-shape, and inverted S-shape. And here you can see the influence that the spinal pelvic alignment has on the cervical spine and vice versa. So here is someone with significant lordosis, kyphosis of the thoracic spine and subsequent kyphosis of the cervical spine. Here you can see someone who has perhaps a flat back syndrome where the head is well forward of the rest of the spine, and in order to see, the patient has to hypolordose their neck, and that becomes sort of a fixed deformity, and that then leads to pain and worsening degeneration as well. So how important is lordosis? So is the non-lordotic cervical spine pathological? I think the evidence is inconclusive. Studies have shown that lack of lordosis does not equate to symptoms. There's a study of young patients who found no difference in pain scores between various cervical spine alignment subgroups, and it concluded that the differences in cervical spine alignment was not due to degenerative changes or muscular spasm. And they theorised that the postural habits of modern society, such as the need for looking at the television, computer gazing, and reading, may be responsible for the change in the modern cervical spine alignment with time. So these days, you know, you're weird if you are not looking at your phone in everyday life. And here you can see the number of injuries had started to spike in 2007, and this was when there was the introduction of the iPhone 1. So everyone's kyphosing or having a tendency to kyphose their cervical spine. So here you can see this is an accelerated view of the aging kyphotic spine in a patient who happened to have ankylosing spondylitis. There's a tendency for us to, as we get older, to adopt an energy-conserving posture, and that's slumping, and that then leads to kyphosis of the spine because you then rely on this posterior tension band in the spine, which is the interspinous ligaments, the facet joints, etc., in the back part of the spine. And you notice, you know, when you're tired, you tend to slouch a bit, and that's sort of you leaning on your posterior tension band. And that's how aging then leads to kyphosis, because the anterior components of the spine, the discs, the ALL, etc., all become degenerate and less able to load bear. Now, studies show that global cervical sagittal alignment do correlate with health-related quality of life indices. The kyphotic cervical spine theoretically places the neck musculature at more strain when it supports the head of the head, with persistently increased pressures on the intervertebral disc, and that then results in accelerated degeneration and worsening deformity. And this was also highlighted in other studies that a kyphotic cervical spine predisposed patients to an increased risk of developing neck pain, deficits, and cervical myelopathy. The most useful parameters of the cervical spine analysis is the lordosis, which is from the body of C2 to the body of C7, the angle there, and also the SVA, which is basically the horizontal distance from C7 to C7 to C2. And that pretty much indicates how far forward your head is in respect to the rest of your body. So this is a study that showed someone who had a greater SVA, so in other words, the distance between C7 and C2, which was greater, was associated with a higher neck disability index. So in other words, more neck pain and disability. Those who had a greater lordosis, so in other words, they were more lordotic in their cervical spine, had a lower NDI. So With respect to alignment changes, hang on, here we go. So again, here you can see the lordosis of the cervical spine can be improved with sagittal correction of the lower spine. So here you can see someone who has a quite a significant hyperlordosis of their cervical spine because the rest of their body is more kyphotic and they have to extend their neck to be able to see. When they have correction, which albeit it's a very big correction, their lordosis is much less. And also too, studies have found that if there's a bigger SVA, so in other words, if the head is further forward, they have worse outcomes than those with less of an SVA on thoracolumbar deformity correction. So it just gives you an idea how everything is interrelated. The cervical spine has an effect on the thoracolumbar, etc., on the outcomes. So is the non-lordotic cervical spine pathological? I think it's inconclusive. There was a study where patients with whiplash injuries were also shown to have similar cervical spine alignments compared to those who are asymptomatic. So this suggests that a loss of lordosis may not necessarily be the result of neck pain. And there are studies that show that kyphotic spine predisposed patients to an increased risk of developing neck pain and deficits, as we spoke about. Interestingly, there was a study that showed that in a lordotic spine, if the canal diameter was less, then there was more disability. In a kyphotic spine, it's quite the opposite. If the canal diameter is less, then it has less an effect on the disability. There's not much in the literature about how a single level ACDF can affect the whole spine alignment, but there is some influence intuitively as well when you think about it. It's just that more studies have to be done about that. So should we aim for lordosis? The relationship between sagittal cervical spine alignment and symptoms in patients prior to undergoing surgery remains imprecise. Therefore, the evidence of its influence on postoperative clinical outcomes is mixed in the literature. It is generally accepted, however, that fusion and kyphosis is not ideal and should be avoided, as it's thought to lead to increased rates of adjacent segment degeneration. Again, it's this load of the head pulling things down on the neck. The International Spine Study Group recently reviewed their multi-centre database of patients that underwent cervical deformity corrections and basically found that patients were more predisposed to this distal junctional kyphosis, so degeneration at the adjacent levels, when the SVA was greater than 50. So the normal SVA is between 25 and 30. And so that's the head moving, head being forward. And if the kyphosis was significant as well, then there was an increased risk of failure at the adjacent levels. Lordosis allows optimal distribution of the weight to the posterior column and less strain on the neck muscles, and has been shown that there are larger improvements in post-op outcome indices when compared to fusion in kyphosis. Does the approach influence outcomes? Answer is no. At this stage, they're pretty much on a par. The only difference, I guess, is the risks involved, the risk of complications with the different approaches. And the two speakers tonight will talk about the pros and cons of each of the approaches. Finally, sagittal alignment in non-fusion surgeries. Artificial discs, which should offer a theoretical advantage because it allows movement. There's not a lot of literature at the moment that is supporting that, but more studies will occur as time goes on, along with endoscopic work. Not much is known about the impact on alignment. And laminoplasties and laminectomies are well known to be kyphosing procedures and leading to more loss of lordosis, and there is evidence that there is more of a risk of axial neck pain after that. So do we have to follow all of these angles and all these parameters of the whole spine for us to be able to do cervical, particularly spinal fusion surgery? No, I don't think so. I think it's there are other factors involved, such as age and bone quality, and the number of levels that need to be managed. So I think it all has to be taken into account and customised as to how far you go with respect to doing all of these angles. I guess how much does one level fusion make on have on the whole alignment of the spine, let alone alignment of the cervical spine, and how much does it really impact on someone's outcome? I think, look, probably 1-2 levels is not going to be too impactful, but at least you can move towards having moved towards a good spinal alignment outcome if you have an idea of this whole spinal sagittal balance concept. So the moral of the story is, first of all, this is how they, in the 1990s, they had many attempts to try to reduce the leaning of the Tower of Pisa. And here you can see this is the most successful in the 1990s, where they attached the cables and they dug on the north side of the tower some holes with a drill in order for the north edge of the Tower of Pisa to fall into and therefore upright itself. Well, I think, particularly with Jenga, the moral of the story is don't be the person that pulls out that block, which then upsets the whole Jenga skeleton, but be that person that adds to the drilling and tries to at least get close to getting good alignment of the cervical spine. Now, we're going to have to stop sharing. We've got our special speakers here. We've got, first of all, Associate Professor Hansen, and he is an adult and paediatric neurosurgeon. He underwent his fellowship in complex spine in Toronto Western Hospital, and he's the immediate past president of the Neurosurgical Society of Australasia and chair of the AO Spine Australia and New Zealand. He's a keen educator and he's instructed spine surgical techniques from as high as the tectum all the way down to the rectum in many countries, and he's passionate about motion preservation and minimal invasive philosophies. And he's going to talk about the anterior approaches, and his talk is entitled Debunking Anterior Cervical Surgery. We will go through all the talks and we'll have question and answers at the end of the final talk.
Thanks, Tanya, for the introduction and for a great talk. Just share my screen. I'd like to thank the AASNS for the invitation to talk tonight, and especially Tanya for the invitation. As she said, I'm going to talk about anterior approaches to the cervical spine. There are my disclosures. So basically an outline of what I'm going to talk about tonight. I'll run through the indications for anterior surgery. I'll talk a little bit on how to get there, hopefully speak a little bit about some of the things to do to avoid some complications, and then I'll just finish off with a few illustrative cases. So indications for the anterior approach, I guess degenerative cases were probably the first reason we looked at going through the front to get to the spine. And Cloud was a big proponent of this in '69. This was for excision of herniated discs. Since then, the indications have expanded, where we now have degenerative conditions for trauma, for osteophytes, oncology, and for biopsy and osteomyelitis. Patient positioning is pretty key for the approach. For the subaxial spine, whether I'm doing an arthroplasty or a fusion procedure, patients place supine. And I generally put a sandbag or a roll under the shoulder blades to help with the extension, or to, in the case of a trauma and there's significant instability, to help stabilize the neck. I generally tape the shoulders for all procedures just to help with the radiography. And I keep the head in a neutral position. Some people turn the head away to relax the SCM muscle, but I don't find it too much of a problem to get in. The landmarks are pretty useful to work out how to get to the spine. We look for skin markers for these landmarks, and I've outlined them there. There is a little bit of change between them, but overall, it's pretty standard for most of them. And certainly I use radiography to help plan the incisions, certainly for multiple levels. For 1 to 2 levels, I can generally do a transverse incision, but if I'm going longer, then I'll look at a oblique incision, which generally runs along the medial border of the SCM. The superficial dissection, there's danger in every level that we look at going through. So we just need to be wary of things. So platysma muscles cut, I generally use the Bovie diathermy to do this. It's a pretty difficult muscle to denervate because its nerve supply comes from the facial nerve and begins in the region of the mandible. The carotid sheath is obviously something that we need to be aware of, and where it divides at the thyroid cartilage is a good landmark to also be aware of. With the superficial dissection, generally when I'm looking at a single level, I undermine the platysma to make space, and then divide the pretracheal fascia. This I do with sharp and blunt dissection, but when it comes to position of the incision, the superior and inferior thyroid arteries can limit the extent to which we can open up above C3, 4, and either or both of these need to be ligated to get to the plane. My fellow recently got into a little bit of strife going into the carotid sheath recently, but just had to remind him that palpating for the carotid and knowing where that is a great landmark on your way in to stay medial to it for the approach to the spine. When you finally get down to the anterior part of the spine, the longus colli are pretty important muscles. I use them for identification of the midline. We've got paired longus colli, and that makes it easy to see where the midline is. And this is important for position of your implants. And it's also important to undermine the longus to get the retractors in so that they're not moving around too much. The longus lie on the anterior surface of the vertebral column between C1 and T3. It's always good to remind yourself of some of the basic anatomy, I think, at times. Once a removal of these muscles is not going to denervate them because they're actually innervated segmentally and laterally from their posterior surfaces. Running along that anterolateral surface of the longus is a sympathetic trunk with the ganglia. So trying to stay medial and undermining this is important. Some of the nerve issues, the recurrent laryngeal nerve is probably the one that gets the most publicity and can be traumatized during the deepest layer of the approach. Trying to protect it with the retractors once you're under the medial edge of the longus is one thing to do. The other thing to try and protect when I'm looking at anterior surgery and reduce the risk of recurrent laryngeal nerve palsy is that I'll get the anaesthetist to check the cuff pressure of the endotracheal tube. This I generally do for 2 or more level surgery, where there's a lot more retraction, and often find that some of the air in the cuff needs to be released, and this helps, I think, reduce the rate of recurrent laryngeal nerve palsy. The sympathetic nerves and the stellate ganglion can also be damaged or irritated at the lower level, which can cause a Horner syndrome. Once again, it's important to stay subperiosteal from the midline and certainly avoid dissecting way out to the transverse processes. Some of the big red things that you need to worry about, the vertebral arteries. Generally, almost 90% of the V1 comes through at the C6 level. It can come in lower 5% of the time at C7. Generally, is safer if it goes higher. The most vulnerable segment, as we know, is higher up at the foramen transversarium after C2. And this can have a tortuous course. So it's important to check your CT, and if you're doing extensive surgery, to have a look at your CT angiogram to see where the vessels are running. I have seen the odd case where a vertebral artery can come in to the disc space in the mid-cervical spine. So that's something to be aware of. Less frequent approaches to the spine that need to be used. We can look at an endoscopic transnasal approach. This can get us to the cervical, to the clivus, and also to the upper cervical spine, down to C3 as possible, depending on extension of the neck. Fine cut CT and MRI use preoperatively to plan the approach. And there's a number of different endoscopes to use now to get us in and quite down low. Benefit of this approach is that we can preserve the oral mucosa and actually start feeds earlier than what I'd normally do for a transoral approach. Obviously, a significant risk is still a postoperative CSF leak, but as with pituitary surgery, having a vascularized nasoseptal flap can be useful to help prevent these things. I think that this gives us quicker recovery times than what some of the transoral approaches do. Transoral approach certainly looks quite gruesome to get in there, but it's a workhorse for anterior procedures high up in the spine. We try and leave the anterior tubercle of C1 because of the attachments of the ligaments there. But it's a bit more morbid than looking at the endonasal approach because of posterior pharyngeal swelling. Certainly, keeping the patient tubed for a day or two can be useful to help with this swelling. And it's important to get a swallow assessment before progressing on to a full diet. For the transoral approaches, it's really important to have a look at your vertebral arteries. As I said, the V2 vertebral artery is most at risk here and can have several different anatomical variants which you need to be aware of. But basically, at that junction at C12, you've got a 3 centimetre window or so for a safe zone of resection of bony anatomy. Working the way further down the spine for fixation of odontoid fractures, 40% of these are type 2. and surgical management can be the gold standard for these. Previously, Harms type fusion posteriorly at C12 with dorsal wiring or screws does sacrifice the mobility a lot with regards to rotation at these joints. Introduced by Bollers and Nakashini, was dontoid screw fixation, where we can preserve motion at C12 for type 2 fractures that have the right alignment of the fracture. By placing a screw across the fracture, we can get good reduction of the fragment and still allow rotational movement. Some of the contraindications for this approach, though, are disruption of the transverse atlantal ligament, and certainly if patients have poor bone quality, other methods might be looked at. The actual incision is reasonably low. It's, as you can see there, lower down at C3, C4. It's important to try and plan your approach. And this is because you need that high angle to get from the, just on the inside of the disc at C2-3, and then to approach up and get bicortical purchase. Using that lag screw, we can pull the fragment back down and compress this. This is done in acute fractures. It's not an approach that I would suggest for fractures that are weeks old, but the healing time and less muscle disruption on the way in compared to a posterior fusion, certainly in the right patient, can be quite useful. So some of the indications that I talked about, I'll show a few cases now to kind of demonstrate this. So first patient had an incidentalloma in the cervical spine following MRI done in 2023 for a stroke and an MCA aneurysm that I fixed for him. Going back and looking at a previous scan from October 2016, we could see that there was a lesion demonstrated in the clivus that time, but it wasn't commented on in the report. We came through the MRI of October 2023 and we saw that the clival lesion had actually expanded, and there was some involvement in the condyles and down towards C2. This patient, I looked at an endoscopic endonasal resection of his clival lesion, and the pathology came back as a chordoma. So this was February last year. He then went on to look at proton beam therapy in Singapore, which for people not in Australia, we don't have a proton beam in Australia yet. And he finished that treatment in October 2024. CT scan that I had done last month demonstrated that he's had no progression of his chordoma yet. And the nice thing about doing this approach through the nose allowed me to not fuse him posteriorly. He kept his stability, and he could still play golf, which was important to him as he hits off one. His post-op scans are still looking quite good. Next case, I had a 76-year-old gentleman that I saw in clinic this week who has a background of 2021. He was diagnosed with a C2 lesion. This was presumptively said to be a plasmacytoma, and he went posterior fusion from the occiput down to C5 at another institution for his significant pain. He was then treated for multiple myeloma, but had an increase in the size of his C2 lesion. So he was referred to me some weeks ago for increased pain. He'd developed some myelopathy, and he had a diagnosis of other spinal lesions. He, as you can see on the left in the CT scan, had the posterior cervical fusion, which looked quite good and had good bony overlay and good alignment, but he had this mixed density lytic blastic lesion at C2, but also had multiple lesions now lower down. I elected for an anterior approach to the lesion that he had at C6, and did a biopsy of that lesion, and he was found to have metastatic chordoma. He does have some signs of myelopathy, and my plan, because of the inability to extend him now with the posterior fixation in line, we'll have to look at a transoral approach to this chordoma to decompress the spine and then allow some SBRT radiation for his control of the chordoma. A presentation that we get quite regularly now, 37-year-old male who came in, who was on methadone and a methamphetamine user, presented to the emergency department for acute neck and bilateral shoulder pain after lifting some furniture. He had worsening symptoms, pins and needles down his arm, but no real significant neurological deficit. The imaging demonstrated a retropharyngeal effusion, and he was put on some IV antibiotics. So this was in October last year, and he demonstrated a prevertebral collection, some osteomyelitis, and he was treated with IV antibiotics. Unfortunately, he progressed whilst on the treatment and had this significant pathological fracture and osteomyelitis at C5-6. His alignment was terrible, and he also had worsening pain. Luckily for him, he didn't have any significant signs of, he had no significant signs of myelopathy. And so it was elected to take him to theatre to look at a 2-level corpectomy to restore his sagittal alignment, which hopefully should keep Tanya happy after her great presentation. And in this case, I looked at a anterior approach with a carbon fiber cage to allow further imaging and to reduce the artifact with that. And then he then required posterior fixation to keep the alignment. Degenerative conditions are also significant, or trauma. And this patient that I had was a 21-year-old male, developed left arm weakness over the previous 6 months. He had some numbness in his arm, and there's some weakness in his left triceps at the graded at 4.5. He was a professional rugby player, and he was unable to play rugby at a top level because of this weakness in the arm. He had this MRI, which at the C6-7 level demonstrated a reasonable foraminal disc. So to him, he couldn't play rugby at a competitive level. Could look at options for him from an anterior or a posterior approach. The position he plays in rugby is as a prop forward, so I had concerns with a posterior approach, possible instability if we looked at a foraminotomy. So this then pushed me to look at an anterior approach. And so the options here were either an ACDF or a cervical arthroplasty. I elected, as he's 21, to look at a cervical arthroplasty to address his function. I think the arthroplasty in a younger person, there is good evidence to show that it reduces the risk of adjacent segment disease, and having movement at this level, I think is useful in somebody of his age. I wouldn't argue against a fusion, and certainly a lot of rugby players end up with fusions in professional leagues in the UK and France, but he's now back to training a few months post-surgery with full resolution of his pain. So I guess take-home messages are that there's multiple indications for anterior surgery, and certainly I like to have a horses for courses approach as to what's best, whether this is something extravagant through the nose or our normal workhorse of anterior degenerative procedures. Need to be aware of potential complicators though, and even a straightforward procedure can have a devastating effect on people. So I'd like to leave it there and say thank you very much for your attention.
Okay, thanks, Mitch. That was a fabulous presentation. You do great work, very impressive reconstruction of the sagittal alignment of the cervical spine. Love it.
So much.
Our next speaker is Dr. David Chan, and he's a neurosurgeon who specialises in minimally invasive spine surgery. He's a life member of the Asia Pacific Spine Society and supports the spine chapter of the Hong Kong Neurosurgical Society as the spine chapter convener. He was awarded the GB Ong Visiting Fellowship from the University of Hong Kong to visit the University of Toronto and New York Presbyterian Hospital, Columbia, as a visiting scholar a few years ago. He is currently the coordinator of the Neurospine Service at Prince of Wales Hospital in Hong Kong. He is passionate in endoscopic spine surgery and participated in one of the first endoscopic lumbar interbody fusion operations in Hong Kong in May 2021. He also participated in one of the first robotic-assisted endolifts with intraoperative CT in Hong Kong the following year. And he's going to talk about posterior approaches and from the open to MIS spine operations with the posterior approach. Thanks, Dr. Chan.
Thank you very much, Tanya. So today I'd like to share the tips and tricks for young neurosurgeons on posterior cervical spinal approach. So I would share on the technical aspects on the cervical laminectomy, posterior spinal fusion. But in particular, I can like to share our experience on utilizing intraoperative ultrasound to assess the adequacy of decompression, and also in some patient consideration of the potential options of using bensile neuroplasty, and I'd share cases on degenerative spine and also on some of the more complex spinal tumors with our 3Fs in some of the more challenging complex spine cases utilizing, in addition to laminectomy, we can consider facetectomy fusion and aiming for functional preservation. So common indications for posterior spinal operations, including degenerative conditions, be it myelopathy or radiculopathy in a patient with trauma, like fracture dislocations, with spinal tumor infections, etc. So posterior spinal operation is a very versatile surgical approach. We have direct access to the posterior element, lamina, the facet joints, pedicles, and is more familiar to us, and achieving decompression, stabilization, and correction of deformity, and restoration of the sagittal coronal alignments. And of course, with the potential options of minimally invasive surgery, like use of tubular retractors, use of microscopes, as well as endoscopic cervical spinal operations. But of course, cons including postoperative pain and also the limited access to anterior cervical pathology. And in certain cases, there could be risk of a CSF leak and a dural tear. And in posterior cervical operation, you can consider open versus MIS. Like for open surgery, can tackle deformity, spinal tumors, or multi-level pathologies or revision surgeries. Whereas for MIS, it's better in tackling a single level pathology and many of the degenerative conditions. So key considerations including patient factors, the pathology, whether it's multi-level or single level, and whether it's the complexity of the case, as well as the team's experience and the resources and equipment. So with an open posterior approach, it allowed wide exposure and it's very versatile, but potentially more tissue trauma and potentially longer recovery. Whereas for MIS approach, you can achieve more with potentially smaller wound with less tissue damage and less blood loss. But the cons is it's a steeper learning curve and potentially limited exposure and also risk of inadequate decompression requiring reoperation. And the risk is particularly higher for cervical spine in contrast to a lumbar spine. And we need to recognize the key anatomical landmarks, be it for open and MIS, trace along the midline, the spinal process, the lamina, the facet joints. Whereas for MIS, you should have a lower threshold in using X-ray and C-arm fluoroscopy, especially for the first few cases. Ensure you're working on the right spinal level and consideration of using navigation. So for the technical aspects, in the positioning, patient will be in prone position for posterior cervical spinal operations, and you can check the alignment. Midline incision for open surgery and subperiosteal elevation to expose the lamina. So for me, just to share with you my personal preference and experience, I would like to drape in a diamond shape. This is good because potentially if I need to extend the incision cranially or caudally, I can do it. And then also I can potentially open the wound wider towards the left and the right. So the diamond shape draping allows adequate exposure in case of emergency. And in some more obese patient, I can use the trimline retractors to go deeper, and also it's radiolucent. So for this patient with a laminectomy and posterior spinal fusion, we can have adequate decompression, achieving decompressions, stabilization, and restoration of the sagittal alignment. So common posterior spinal operations, including laminectomy, laminoplasty, foraminotomy, posterior spinal fusion, or even back approach for some more challenging cases. So I have a few case illustration. The pros and cons as shown. You can see we can have achieved motion preservation with laminoplasty or laminectomy alone. Whereas for PSF, we can't achieve motion preservation. But at the same time, the risk of kyphosis is less with posterior spinal fusion. But of course, the potential complications, including adjacent segment disease and also risk of hardware failure. Whereas for laminoplasty, there's a risk of closure of the hinge, and laminectomy alone have risk of kyphosis and even instability. So some of our patients, a 71-year-old gentleman, slipped and fell on level ground, and with bilateral upper limb power down to 1/5, lower limb power 3/5. You can see extensive OPLL with cord compression. So for this patient, we perform laminectomy for decompression and also posterior spinal fusion for stabilization. And then subsequent scan showing good bony fusion of the facet joint. And this is the axial cut. With laminectomy, we can do a more aggressive bone drilling all the way to the lateral recess. But in this case, it's better to do a posterior spinal fusion at the same time. Otherwise, there's risk of instability. And watch out for the vertebral artery in the front. Of course, in others well-selected cases, we need to consider the option of duroplasty by having a longitudinal duro opening at the dorsal side, and then putting in stitches and expanding the spinal canal. This is the intraoperative ultrasound showing you the large OPLL in the front, and then after expansile duroplasty, there's adequate decompression, allowing dorsal shift of the spinal cord and achieving adequate decompression by posterior procedure alone. You can still see the OPLL compressing from the front. And this is this ultrasound sagittal cut showing you the adequate decompression of the spinal cord with the dorsal shift of the cord away from the OPLL from the front. Another case with a large OPLL at the ventral side. So with intraop ultrasound, you can assess adequate decompression of the cord as well as the nerve root. So for some other cases, you can see like another large OPLL and then adequate decompression. So patient had improved myelopathic symptoms, but worsening radiculopathy after the initial operation. As you can see, there's still lateral recessed stenosis, like in this case. So for this type of patient, we need to perform, in addition to laminectomy and fusion, we can achieve better decompression of the exiting nerve root by performing anterior spinal operation, like in this case, corpectomy and anterior spinal fusion as well, and remove the OPLL. So achieving decompression of both the spinal cord as well as the exiting nerve root. So this was another patient with OPLL. And after laminectomy, we also perform a duroplasty. And post-op MRI scan, you can see the nice duroplasty and adequate decompression of the spinal cord. So these are the pros and cons of laminectomy versus laminoplasty and PSF. So for laminoplasty, I think it's ideal for patients with preserved lordosis and no gross instability. Whereas for PSF, you should consider fusion in patients with kyphosis, instability, or OPLL extended all the way up to C2. And tips and tricks on tackling potential complications, such as C5 palsy, you might need to consider doing foraminotomy for more adequate decompression. Okay, and also risk of post-op kyphosis, so need to add fusion in patients at risk. And some other tips in some of our patients in which you might need to, in addition to X-ray, you might need to do intraop CT or O-arm spin. Then remember to use a radiolucent Mayfield head clamps to fix the head. like in our case, using intraoperative CT, and like in other patient with OPLL. So we can keep the retractor by using the trimline retractor, which is radial lucent, in which it would only generate minimal artifacts from the intraoperative CT. And this can facilitate the registration and putting in the pedicle screws. And sharing on some more other complex spinal tumors, like dumbbell spinal tumor, in which there's extension of the tumor all the way to the lateral recess. And like this lady with a recurrent dumbbell schwannoma, you can see previous laminectomy. Now the residual tumor is keep on growing and then have some mass effect on the spinal cord with bony erosion. So it's important to have a good pre-op planning, and also with CT reconstruction, which shows the bony defect, and also do a CT angiogram, which can localize the cause of the vertebral artery to minimize the risk of intraoperative vertebral artery injuries. And for this patient, we perform, in addition to laminectomy, we also perform facetectomy, the level above and below, to expose the tumor and the exiting nerve root. And then after tumor excision, we can do a watertight closure, and also duroplasty or watertight closure. We close the foraminal side of the dura before closing the dorsal side. And then this is the defect after tumor excision. And then we perform posterior spinal fusion. So the facetectomy, fusion, and function preservation. Another dumbbell spinal tumor with cord compression, is important to perform the CTA again. So you can see this time the VA is pushed ventrally and towards the medial side. So with facetectomy and fusion, we can achieve good functional outcome with posterior spinal approach alone. Another dumbbell spinal tumor with the vertebral artery pushed towards the ventral side. It's important to trace along the foraminal segment of the vertebral artery during dissection. And facetectomy allowed adequate tumor exposure. And also the use of navigation can facilitate placement of pedicle screws and lateral mass screws. Another patient with a recurrent dumbbell spinal tumor with cord compression. And then facetectomy and fusion can achieve a gross total excision of the tumor and preservation of function. And we in some of the other patient, we put the tracker at the Mayfield head clamps and can achieve a good registration and introp navigation. And with a good short-term and long-term outcome. There's this last case of complex dumbbell spinal tumor with bony erosion and a large bony defect. So we again perform facetectomy and fusion in addition to laminectomy, and then closure with duroplasty. And patient have a good outcome with improvement of motor evoked potential. So compare open versus MIS tubular microscopic surgery versus endoscope. The incision of open surgery is large, but is ideal for multi-level pathology. Whereas for endoscopic surgery, the incision can be very small, but the learning curve is very steep and is not suitable for multi-level pathology or more complex spinal operations. And the new emerging trends in posterior cervical spinal operations, in addition to using the tubes, would be the use of endoscope as well as even the exoscope, and use of navigation and robotic assisted placement of screws. But the challenges and limitations of minimally invasive spinal surgery is the steep learning curve. So you need to be very familiar with the microscope, endoscope, exoscope. and with the limited exposure is not suitable for multi-level or complex spine pathologies. And you need specialized instruments, equipment, and imaging facilities. And also the risk of incomplete decompression with residual neurological deficit or requiring reoperation. And also risk of dural tear, CSF leak, and it's more difficult for you to repair the dura with endoscopic or MIS approach. And we need to, so the tips for younger, newer generation spine surgeons is to start with simple cases, start with single level pathology to build up confidence, and use C-arm X-ray fluoroscopy with a lower threshold at the beginning so that you always confirm and reconfirm the correct vertebral spinal level and the placement of your retractors, MIS tubes, or your endoscope, okay? And collaborate with experienced surgeons, learn from mentors at the initial learning curve, and joining professional activities like the AASNS here. So thank you very much, and happy to take any question. Thank you.
Thank you, Dr. Chan. Does anyone have any questions for Dr. Chan or Professor Hansen? Oh,
yes,
Professor Shashank?
I do have a question to the panelist. It's not unusual that you go for cervical spine surgery and you lose your potential, of course, when you use neuromonitoring. And so what would you suggest to the young neurosurgeon that, they are doing posterior approach for, say, some dumbbell tumor, they lose the potential, what to do? To stop surgery, to wait? How would you approach this event, which is, not very unusual? It's happened, at least to us.
Yeah, thank you. It's an excellent question. I think the Toronto group from Professor Michael Failing's recent publication saying this can be an intraoperative spinal cord injury, so ISCI. It's great that they suggest like a formal checklist. So everyone stop and then check with the anesthetists, the surgeons, and then the electrophysiological technicians. And then, so I guess just like in the cockpit, everyone go through the checklist in a systemic way, check the blood pressure, check the hemoglobin, check the glucose, and then of course, for the neurosurgeons, check your instruments, check the imaging, and then work as a team. So it's good that we are well prepared with the guideline and the checklist so that we make sure we're not missing anything important when there's this surgical spinal emergency.
So Dr. Chan, when you are operating and you get a loss in motor function, do you stop straight away and close up, or do you
so
do you take it with a
can
grain
share
of
some
salt
of
if
the
you're nowhere near?
example.
Yeah.
I think it was maybe when I first started the endoscopic spine surgery, and the patient has a drop in the SSCP, and then we checked the MEP, it also dropped. And then ending up, I stopped, and then luckily the patient improved in around 5 to 10 minutes. And then I realized what it was the water pressure, because we started with a new water pump for the endoscopic spine surgery, and the water pressure was too high. So like creating like an epidural mass effect. So luckily that was like reversed once we stopped and released the epidural fluid. So it's very important that we use intraop monitoring, even in endoscopic spine surgery at the beginning.
I think I go the other way. I think the use of intraoperative monitoring is for the right indications. I think endoscopic certainly where you've got pressure going on, but some of the time if you've got a cord at risk, you're not actually going to get good baselines to start with. and then so you have to be aware of what you're doing. If you lose your potentials partway through, you also need to think about what you've done. If there's a slip or something, then obviously you know that something's gone wrong. If you're correcting a big deformity, then yeah, that's the time that I'll use monitoring. But I think you've got to be aware of what you're using it for and how it's going to change your practice. Endoscopic, certainly I would use it with the fluid changes. But for some of the other indications, I don't use it for all cervical spine surgery at all.
Yeah.
Who
Agreed.
uses monitoring for all ACDFs? I mean, I know some people do. Does anyone here use monitoring for all ACDFs?
Look, I don't. Having done my
No.
fellowship with Michael Failings at Toronto Western, all spine surgery had monitoring, including microdiscectomies, lumbar microdiscectomies. So, but certainly that's not my practice now.
David, what do you use it for?
Yeah, so I guess for just simple, straightforward cases, I think we can be more selective. Yeah.
Dr. Hansen,
I think if there's any signal change in the cord or there's any significant compression of the cord, I think personally it behoves you offer it, you owe it to the patient to use neuromonitoring and to take into consideration, depending on what you're doing, if there is a drop, to stop, because you can always go back some other time, rather than have the patient wake up quadriplegic.
In our system, though,
Sinha?
that's a significant
Yes.
a significant cost, because we don't have in-house neurophysiologists, so we have to pay for them to come in. So there is something to consider. Not that you don't want to use it when it's really necessary, but to know when it actually is necessary is an interesting question. Sorry.
Dr. Sinha?
yeah,
Okay.
Dr. Hansen. Yeah,
Yes.
Dr. Hansen. In anterior approach, we don't go for angiography. In any case, either we go transoral or cervical, we don't do angiography. So, at how many times you came across the vessels, they were prone for injury? Number one. Number two, after surgery, post-operative period is very, very important in these patients. So what are your instructions to patients, or this part is taken by physiotherapist?
Thanks for your question. So CT angiogram, I use mainly for tumor surgery or for upper high cervical surgery to see where there is a lot more anatomical variance and it's more at risk. Certainly for standard ACDFs and even corpectomies at multiple levels, I won't bother to get that, but it's more the larger reconstructions. The trauma surgeons, every fracture, it seems, gets a CT angiogram now. There's not good indication for any good reason why to do that. But so I guess the CT angiogram's done most of the time for me in trauma. But yeah, I as you say, I don't do a CT angiogram on everybody. But I think you need to be aware of the, once again, the proper cases and the horses for courses approach. With regards to postoperative care, for degenerative spine and so arthroplasty and ACDFs, I don't put anybody in a orthosis afterwards. I have the patients moving as quickly as possible. I prefer them to, I give them a set of simple exercises to do, which starts on day one, and they engage with the physiotherapist. I ask them to do that by week 2. Really, I don't put any restrictions on degenerative patients, certainly the arthroplasties. And I operated on a colleague last year who ignored my instruction not to swim for 2 weeks, but he was surfing the day after surgery. So yeah, I don't think there's a lot of risk involved if your carpentry is actually quite good. So I want my patients moving quickly.
Dr. Ng, do you have a question?
Yes, I do. I was seeing Dr. David's pre-op planning. It was really beautiful in the 3D. Just want to check which system you use. Is it a brain lab? And
Yes.
second question would be, you showed some videos of the ultrasound. Do you use that routinely now or for selected cases? Thanks.
Thank you. Yes, we are using the brain lab navigation system, the element, and also in selected cases we use it with the brain lab robotic arm as well. So yeah, for most of my cases, cervical, I perform laminectomy and ultrasound to check the adequacy of the decompression. Only minority amount of patient, only I guess less than 5% requiring duroplasty. 95% laminectomy alone is great with adequate decompression, especially in the lateral recess.
Professor Shashan?
Yeah, just 2 comments. You know, the issue of neuromonitoring, yes or no, I think at least in our hospital, it's not in our hands anymore because it's very strongly derived by the medical insurance company. So it will be very difficult to defend the case when you did your simple ACDF and the patient ended up with neurological deficit and you didn't use the monitoring. You will have a problem. So we just follow the rules, and the rules in cervical spine, thoracic spine, and intradural lumbar spine. We use in-house neuromonitoring as a routine, but that's may or may not also happen in Asia and Australia region. The other point is the issue of angiography in cervical trauma. We always do a CTA, and if there is any suspicion, we do a full angio. I always say to myself and also to my doctors that I never regret an angio that I did for a patient. I did regret the one that I didn't perform. Dissection is not very rare cases in cervical trauma. You see them, and some of them can be corrected. So that was my 2 comments.
Thank you. There's a question from Professor Drummond. What's your length of stay for a simple ACDF or disc replacement? Maybe Professor Hansen first.
Probably 95% of my patients go home the morning after surgery.
And Dr. Chan?
Yes, yeah, for simple 1 level ACDF or artificial disc replacement, yeah, the next day.
Are you going to be happy
Could
to
that be
move
like
to
a
day
20
only? Are you going to be happy to move to day only, which is what our hospital's angling for us to do?
Got same day admission and same day
Yeah,
discharge.
I mean, for first case
23
case
hour.
of the day, go home
Yeah.
that night. No overnight stay.
Yeah, we tried, but still have some resistance from the patient and the relatives. And Hong Kong, I guess, is relatively small, so they would rather go the next day.
It's interesting because our hospital's starting to not give them a bed at all, so they go off the operating trolley onto a reclining chair. So
Oh, interesting.
I guess the issue is every 2 years or so there is a
Yeah.
hematoma.
Yeah.
And that hematoma's more than 12 hours after the surgery.
Yeah.
Certainly, you only need one of those and an arrest to, like, all of my patients go to intensive care post-op and they get discharged from intensive care in the private. In the public, we don't have access to the beds. But yeah, you only need to open up one on the ward for you to and have the 30-year-old arrest from from a hematoma to for me to gauge that. And if medico-legal problem for a quadriplegic 30-year-old, it's a $20 million payout.
Yeah, no, I completely agree. I mean, it's, you know, it's an interesting interesting argument. I mean, the US, it's mostly a day procedure, ambulatory surgery, but they have a completely different follow-up paradigm to what we have. And certainly we're only doing it for people who live locally, have someone with them, etc. First case of the day. But it's, yeah, it's I don't know where it's going to lead.
Dr. Sinha, did you had your hand up previously?
Yeah. Just I want to ask anyone in cervical injury after posterior fixation, there is a lot of cord edema. Anyone doing dual opening and dual decompression? Should I repeat? Yeah.
Yes, please.
So with cord edema, do you do a duroplasty? Is that what you're asking?
No, yeah. Dura, we just open the dura, decompression of dura. So what is the results?
Oh.
Anyone doing? Yeah.
So is this like in the scenario of an ACDF? Do you open? Oh, okay. I see what you're saying. Do you open the dura?
Yeah.
In trauma for cord edema.
Yeah.
Yeah, I perform duroplasty, especially in spinal cord injury, very edematous spinal cord. Just like I guess for us neurosurgeon used to do decompressive craniectomy and duroplasty. So
Yeah.
same for the spinal cord.
Professor Shashan, another
Yeah,
comment?
Last question, Professor. Talking about post-op hematoma after ACDF, will you guys use drain on routine basis, or what will be the indication to put drain?
There's no drain. I never put
No
a
drain.
Yeah.
Yeah, I
Never.
had one case where I didn't use a drain and they got a hematoma that I had to evacuate and almost had a respiratory arrest. So I use drains all the time now.
But all of the hematomas that I've seen, not mine, knock on wood, have had a drain in. So I don't think it helps.
Yeah, I
Just
put them in
one quick-
about 10% of the time. So if something's oozy, then I'll put in a mini vac. But yeah, that's all.
What's everyone's preference for after perhaps an ACDF with respect to surfing/skiing for patients? And is there a time, or do you do a scan to check if there's bony fusion? What's your criteria for letting patients, particularly athletes, elite athletes, get back into their traumatic sports?
I think for me, I think an arthroplasty is different to ACDF. So I'm happier for them to get back to do that earlier. If I've got an athlete or somebody that's doing different sports, certainly I won't use an integrated or like 2-screw construct or a standalone ACDF without screws. If they really want to get back to things quickly, then I'll use a 4-screw construct so that they can get back to doing contact sports within a few months.
Dr. Chan?
Well, I'm the other way around. For ACDF, I let them mobilize earlier. I guess this is a pretty solid construct. Whereas for arthroplasty, actually, because we have a case like the arthroplasty is potentially too mobile, because we do a parallel distraction intra-op and then loosen all the ligaments. So I want to wait for the interface between the implant end plate and the upper and lower body to fuse before they have a too vigorous exercise. That's why I would keep them have a soft collar for like a few weeks.
Yeah, I guess I use a keeled arthroplasty, which stops translation.
Right.
So the arthroplasty is only going to go forward if it's an issue, and a keeled implant, I think, has less translation and so has less propensity to move around.
Right.
And when do you discharge your ACDFs?
Also,
do you check for bony fusion?
You see that? No, no.
Discharged from outpatient clinic.
Oh, so for us, a public system, we keep them follow up for a long time. So many of them follow up for more than 3 to 5 years. They're just coming back every 2 to 5 years, and yeah. So
My
we have a
patient,
pretty good long-term follow-up.
Why is that?
Because our primary care system is we share the workload together. So for post-surgical cases, the GP expecting us to follow up the patient. But of course, some patient would have long-term implant failure as well. So we are seeing them maybe once every 1 or 2 years.
yeah, I guess I see mine at 6 weeks and 6 months, and they're discharged.
I do a plain X-ray at 6 months, and then I do a CT about a year or 2 later, because I'd just like to see bony fusion and or nice alignment, etc. So I guess it varies.
Yeah.
Oh, Professor Drummond.
Well, the reality is, whatever imaging you do, sometimes you don't see bony fusion for actually a long time, but the patient's fine, or it's partial, a small bridge or whatever. And so I used to image them, but now I'm like, they'll come back if there's a problem. That the imaging appearance doesn't seem to correlate with their outcome with regards to either neck pain or their radicular pain. So I kind of gave up on it.
Yeah.
We have two questions on the webinar chat, Dr. Eric and Dr. Rahman. They are allowed to
Yes,
talk.
Are they going to talk, or do you want me to read out? I'll read out a question that was typed. After fusion surgery, do you still use cervical collars post-op, and for how long?
No, I guess for our ICDF, the construct is very, very strong and rigid. So no rigid neck collar for my side.
The only time I use it is if I've done an ACDF for something like a pillar facet fracture. So I'm actually wanting that I'll probably leave that on for a month afterwards, just so that I don't have to look at a 360 fusion for those. So I can keep my construct shorter. But otherwise, no, I don't use a collar at all.
Mitch, I noticed with your 2-level corpectomy, you backed up with screws. Do you back up a 1-level corpectomy with screws?
No. So single level, I wouldn't. The failure rate for a 2-level corpectomy is up around 50%. And certainly, that was going into active infection. So I was a bit more worried about the construct and worried about the bone quality. And so that's why that one got backed up. Sometimes depends if I do a full corpectomy. If I'm kind of just doing I'm after a medial decompression, then I can not take all of the lateral elements. So there's still a degree of stability there laterally, then you might get away with it. But generally, if I go to 2 or 3 levels corpectomies, then I'll back them up.
Okay, great. Well, thank you for
There's one more question in the Q&A from our friend Dr. Perzad from Afghanistan, which is actually quite a good question. What's the advice for infective complications of ACDF, which is rare, but when it happens is problematic? Maybe Dr. Chan.
Yes, I agree. So it can be very troublesome. And of course, I remove the artificial implants. But interestingly, for these infective cases, after completing the course of antibiotics, they have very good union, so a very solid union in some of our cases. But yeah, remove the hardware, remove the plates, remove the screws, and yeah, antibiotics. But of course, ultimately, we might need to use other crest graft or other grafting.
In a fusion construct, I generally won't remove the implants. I'll check if there's osteolysis. They'll often get a washout, but I don't really find that there's too much issue with the implant. And as you say, in infection, you get grape fusion most of the time. So as long as you can control the prevertebral collection, and there's no post-vertebral collection causing cord compromise, then generally I'll leave it and treat with a washout and see how they go.
Okay, well, I think we'll wrap it up there. Thank you everyone for contributing to tonight, Dr. Chan and Professor Hansen. As you can see, there are quite a spectrum of how to manage cervical spine issues. And I think the key maybe is for the young neurosurgeons is to always ask your mentors who have the experience, and to ask opinions of many colleagues if you can.
Before we close, can we take a snapshot for everybody who's...
Dr. Tanya, your presentation was excellent with lot of physics and difficult surgeries. We should have we should have prevention awareness program for deformity like road safety. We should have awareness for prevention of neck deformity program nowadays.
Well, I'm a born again anterior surgeon. It just once I got a feel of what all the orthopedic spine surgeons are doing. Yes, they operate crazily, but it just makes sense to me.
Yeah.
Okay, everybody turn on your camera. I'm going to take a snapshot now. 1, 2, 3. Bye.
Bye.
1, 2, 3.
Bye.
Thank you very much.
Thank you.
Thank you. Thank you for your participation.
Thanks, Vincent, for your help.
Thank you.
Okay.
Thank you.
Thanks, David. Thanks, Mitch.
Thank you.
Appreciate
Thank
your
you,
help.
Tanya. Thank you, Mitch. Thank you, Vincent.
Thanks, David.
Thanks.